Let's go, my beloveds, about ectopic pregnancy. Take your pens, papers, and let's go. So, these questions that misunderstood or maybe confused actually, questions that confuse on your big exams. So, vast majority of ectopic pregnancy occur in the fallopian tube, of course, but not exclusively. While over 95% of ectopic pregnancies implant within the fallopian tube, of course, most commonly it's an ampulla. They can theoretically implant almost anywhere outside the uterine lining where decidualization can occur or adjacent tissue allows invasion. This includes the cervix, ovary, abdominal cavity, on bowel, omentum, liver, and even within a previous cesarean section scar. Why so important? Always maintain a high index of suspicion for ectopic pregnancy in the pregnant patient presenting with a pain or bleeding, regardless of expected location. Ultrasound evaluation must carefully scrutinize the adnexa, cervix, and prior C-section scars if applicable. Atypical locations often present later or with unusual symptoms, making diagnosis challenging. Next point. A great masquerader ectopic pregnancy is great masquerader. The clinical presentation of ectopic pregnancy is not notoriously variable. It can mimic miscarriage, pelvic inflammatory disease, appendicitis, ovarian cyst rupture, torsion, urinary tract infection, you name it. Even normal intrauterine pregnancy with complications like a corpus luteum cyst rupture. And you will be asked about that, my beloveds. So, clinical importance of that. Ectopic pregnancy must be on the differential diagnosis list for any woman of reproductive age presenting with abdominal pelvic pain, vaginal bleeding, or an amenorrhea. Do not rely solely on the classic triad, pain, bleeding, amenorrhea. Actually, this is a classic triad of noted, pain, bleeding, amenorrhea. So do not ectopic pregnancy. So don't rely solely on this triad, classic triad, pain, bleeding, amenorrhea, as many patients do not present this way, especially early on. A negative pregnancy test effectively rules it out. But a positive test necessitates its consideration until an intrauterine pregnancy is confirmed. About ruptures. Rupture, of course, is a life-threatening emergency, my beloveds. The fallopian tube or other implantation site lacks the structural integrity and vascular regulation of the uterus. As the ectopic pregnancy grows, it can erode through the tissue and major blood vessels, leading to rupture and massive intra-abdominal hemorrhage, so-called hemoperitoneum, because it's in the peritoneum it's a problem. Why so important? This is the primary reason ectopic pregnancy is dangerous, my beloveds. Clinicians must rapidly identify signs of rupture, severe, sudden onset of abdominal pain, hemodynamic instability, that is hypotension, tachycardia, shoulder tip pain, referred pain from diaphragmatic irritation by blood, so-called Kerr's sign, referred pain from diaphragmatic irritation by blood. Means a Kerr's sign. Actually, also we'll be asked about this Kerr's sign. Then, dizziness, syncope, and signs of peritonitis, rebound, treatment, and guarding. So you have to, and you'll be asked about that. So you must rapidly identify signs of rupture. I repeat, severe sudden onset abdominal pain, hemodynamic instability, so tachycardia, hypotension, shoulder tip pain, dizziness, syncope, signs of peritonitis, rebound, tenderness, guarding. Rupture ectopic pregnancy requires immediate resuscitation and emergency surgical intervention, usually laparoscopy or laparotomy, it depends. Then about HCG, human chorionic gonadotropin dynamics differ significantly from natural intrauterine pregnancy. In a variable intrauterine pregnancy, serum beta HCG levels typically double. We used to talk about that. Typically double approximately every 48-72 hours in early pregnancy, in most ectopic pregnancy and non-viable intrauterine pregnancies. The rate of rise is slower, may plateau or even decline abnormally. Why it's so important? Serial beta HCG measurements are crucial when transvaginal ultrasound is non-diagnostic. For example, pregnancy of a known location, PUL, pregnancy of a known location. An abnormal rising of plateauing beta HCG levels significantly increases suspicion for ectopic pregnancy or non-viable intrauterine pregnancy. However, some ectopics can have near normal doubling times initially, so HCG levels must always be interpreted in conjunction with clinical findings and transvaginal ultrasound results. Transvaginal ultrasound, TVUS. Transvaginal ultrasound is the cornerstone of diagnosis, of course. We can say it's a gold standard. So transvaginal ultrasound allows high-resolution imaging of the pelvic organs, often enabling visualization of the adnexal mass, the ectopic gestation itself, sometimes with the yolk sac or fetal pole, an empty uterine cavity, and or free fluid, blood in the pelvis before rupture occurs. Why it's so important, my beloveds? The goal of transvaginal ultrasound is to confirm an intrauterine pregnancy. If beta HCG is above the institution-specific discriminatory zone, typically 1,500, 1,500, up to 3,500, the level of which an intrauterine pregnancy should be visible on transvaginal ultrasound, and the uterus is empty, suspicion for ectopic pregnancy is very high. The definitive diagnosis is made by visualizing a gestational sac with a yolk sac or fetal pole outside the uterus. Absence of these findings doesn't rule it out. An adnexal mass or significant free fluid in the context of a positive pregnancy test and empty uterus are highly suggestive. About methotrexate, my beloveds. Medical management with methotrexate is a viable option, but for select patients. Methotrexate, a folic acid antagonist, targets rapidly dividing cells like trophoblastic tissue, effectively stopping the growth of the ectopic pregnancy and allowing the body to reabsorb it, thus avoiding surgery. Problematic surgery, of course. So methotrexate is suitable for hemodynamically stable patients with an unruptured ectopic. Specific size criteria: small, less than 3.54 centimeters. Specific beta HCG levels, beta HCG levels, for example, less than 5,000. Non-fetal cardiac activity detected on transvaginal ultrasound, and who are reliable for follow-up. Contraindications: breastfeeding, immunodeficiency, liver disease must be ruled out, of course. That's a methotrexate problem. Careful patient selection and meticulous follow-up of beta HCG levels until non-pregnant levels are reached are mandatory for safety and efficacy. About risk factors. My beloveds, key risk factors increases likelihood, but absence of them doesn't rule it out. Factors that damage the fallopian tubes, or alter tubal motility strongly predisposed to ectopic pregnancy. However, up to 50% of women with an ectopic pregnancy have no identifiable risk factors. Why it's so important? eliciting a history of previous ectopic pregnancy, highest risk factor. Pelvic inflammatory disease, tubal surgery, including tubal ligation, use of intrauterine device, especially progestin only, history of infertility, what else? Assisted reproductive device, no technology, ART, assisted reproductive technology, smoking, and advanced maternal age should heighten suspicion. However, never dismiss the possibility of ectopic pregnancy solely only because the patient lacks these risk factors. Heterotopic pregnancy means coexisting intrauterine pregnancy and ectopic is rare but increasing. This involves having two simultaneous pregnancies, one correctly implanted in the uterus and another located ectopically. While naturally rare, so 1 on 30,000 pregnancy, 1 in 30,000 pregnancy, its incidence rise dramatically. So 1 in 100, 1 in 500, with the use of ART. Now these devices are assisted reproductive technology, like in vitro fertilization, for example. No, in vitro fertilization, of course, the most common. No, I suppose. So clinical issue of that. Finding an intrauterine pregnancy on transvaginal ultrasound doesn't definitely rule out a coexisting ectopic pregnancy, especially in high-risk patients. For example, those undergoing fertility treatments, in vitro fertilization, etc. If a patient with a confirmed intrauterine pregnancy presents with significant pain, adnexal mass, or free fluid, a heterotopic pregnancy must be considered. Management is complex, aiming to treat the ectopic while preserving the intrauterine pregnancy if possible. Next point. Ectopic pregnancy can impact future fertility, of course. The underlying tubal damage that may have caused the first ectopic or the treatment itself, especially salpingectomy, removal of the tube can reduce a woman's chance of future spontaneous conception and increases high risk of repeat, unfortunately, ectopic pregnancy, God forbid, up to 10-15%. So clinical importance of that. Patients require sensitive counseling about future fertility prospects and decreased risk of recurrence. Salpingostomy, incision into the tube to remove the ectopic preserving tube, salpingostomy, high technique, may be considered to preserve fertility in selected cases, but carries a risk of persistent trophoblastic tissue and potentially higher repeat ectopic rates compared to salpingectomy. Rhesus negative women who are unsensitized require Rhesus D immune globulin administration. About progesterone, serum progesterone levels can aid in differentiating pregnancy location viability. Progesterone is essential for maintaining early pregnancy. Levels tend to be lower in ectopic pregnancies and non-viable intrauterine pregnancies levels tend to be lower in ectopic pregnancy and non-viable intrauterine pregnancy compared to healthy intrauterine pregnancy, my beloveds. Why so important? While not diagnostic alone, and single serum progesterone level can be helpful, particularly in the context of pregnancy of unknown location. A very low level, for example, less than 5, no nanogram on milliliter, less than 5, is highly suggestive of a non-viable pregnancy, either ectopic or failing intrauterine pregnancy. And a high level, more than 20-25 nanogram milliliter, makes an ectopic pregnancy less likely, though not impossible, and is more consistent with a viable intrauterine pregnancy. Intermediate values are less helpful. It's often used in conjunction with serial beta-HCG and transvaginal ultrasound. So largely sufficient. Yes. It's all about your confused questions of the previous years. I suppose it's all this. That's all. So thanks for your attention. Don't forget to follow and subscribe my Dr. Y YouTube channel, as well as my Telegram private channel. So how to find my Dr. Y, WHY, the same name, huh? In Telegram, you tap in searching mode, Dr. Y. Dr. Y, it's me. WHY, Dr. Y, without question mark, of course, Dr. Y. In Telegram, you find this, you click start and you choose your plan. Stay blessed.